And before you start, I really wish that all those who are attending keep your videos on if at all it is possible. It's better to be interacting with people rather than boxes. Go ahead.
Is it visible?
Yes, yes.
I am presenting a case of 10-year-old female child named P, daughter of Mr. N and Mrs. A, living in Ahmedabad. Informant was mother. Information provided by mother was reliable and adequate. Complaint of physically aggressive behavior since 5 years. History of presenting illness. Patient was relatively calm till the age of 5 years. Gradually, she started having behavioral complaint. The complaint was insidious in onset. Symptoms were continuous and non-progressive in nature. Whenever she is fixated on getting something or doing something, for example, if she wants any toy, if she wants to play with a phone, and in such cases, if her demands are not fulfilled, she tends to turn aggressive and throws objects like glass, remote, phone, sometimes food, or does physical harm to people around her by biting, punching, slapping, or pulling others' hair. To stop such behavior, the relatives have to distract her by taking her outside for a walk. Such behavior lasts for 30 minutes to 1 hour and occurs 2 to 3 times in a week. She is not going to school. She goes to Anganwadi. She remains quiet, composed, and peaceful during regular hours. But when her parents come to pick her up, she turns aggressive and pulls hair off the kids around her. Due to history of such behavior, other schools are not accepting her admission. When more than 10-12 people are gathered in her house, she gets irritated, and according to mother, she has dislike for noise created during social gathering. Past history. History of fall down from the bed at the age of 3 years. After injury, she was unresponsive for 4 to 5 minutes with uprolling of eyeballs. Her parents took her to the hospital. MRI was done. Exact MRI findings are not known by the mother, but mother reported that at that time, doctor told her that there was some injury to the brain. She started vomiting, 10 to 15 episodes of vomiting per day, which continue for 5 days. In investigation, there was high blood ammonia level. Then medication was started, which continued for 1 year, and mother stopped medication due to excessive sedation. History of typhoid fever at the age of 6 years. After 3 to 4 days, there was fever along with that, twisting of limbs and uprolling of eyeballs. Parent took her to the hospital. Then again she started having complaint of vomiting. In investigation, there was again high blood ammonia level and medication was started. In past 4 years, multiple time history of fever. Exact episodes are not known by mother, with history of dengue and pneumonia also. Currently, patient is on some medication from query pediatric neurophysician, but no documents available. Family history. Patient's parents has non-contiguous marriage. Patient's maternal grandfather died 8 years ago at the age of 55 years due to oral carcinoma. There was history of tobacco chewing in last 30 years. There was no any family history of intellectual disability and no any family history of heritable disorders. Personal history, antenatal history. It was unplanned conception, unwanted child. Mother also went for termination of pregnancy, but eventually they decided to continue pregnancy. Mother had history of fall down. She slipped on bed floor at 4.5 months of pregnancy. She felt shock in abdomen at that time and started abdominal pain. Due to query threatened abortion, she was advised to take rest. History of fever 2 times during pregnancy. Nutritional status of mother during pregnancy was adequate, and mother reported there was a sluggish fetal movement during antenatal period. No history of no history of gestational diabetes, hypertension, jaundice, or X-ray exposure. No history of bleeding during late pregnancy. No any RH incompatibility, potential harmful medication or substance abuse. No history of any infection or STD. Natal and neonatal history. It was full-term delivery in the hospital. Cesarean section was done due to breech presentation. Mother reported that baby did not cry immediately after birth. There was a delay in the birth cry. Birth weight was 3 kg. No history of any head injury during birth. No any multiple pregnancy or no history of any congenital anomaly. Postnatal history. History of jaundice. After 5 days after birth, family members noticed yellowish discoloration, and then history of NICU admission for 5 days for the same. No history of any infection, feeding problem, no any failure to thrive, and no any injury. Feeding history, exclusive breastfeeding up to 6 months and weaning at the age of 2 years. Developmental history, gross motor milestones, neck holding achieved at 8 months, sitting without support at 12 months, stand without support at 18 months, walk, run, and box up and down at 2.5 years, ride a tricycle at 8 years. Fine motor and cognitive milestones, scribbles at 8 years, identifies body part at 7 years, tells her address, not achieved yet. Language milestone, dissyllables at 3.5 years, 2 to 3 word sentences not achieved yet, knows her full name and gender at 8 years, tells story or poem or asks meaning of words not achieved yet. Social and adaptive milestones. Social smile at 4 months, recognizes mother at 7 months, waves bye-bye at 7 years, copy parents in the task and feeds independently at 7 years, brushes her teeth, bowel bladder control and cooperative play not achieved yet, dresses and undresses. Patient at the age of 10 years can undress only. So there are delayed history of milestones. Immunization history, exactly not known by mother, but according to mother, she has been given all scheduled vaccine as per her age. Housing history, own house, 2 rooms and kitchen per 6 person, sanitation facility available, electric and water supply available 24 hours. Scholastic history, at the age of 5 years, admission into normal school, but due to her behavioral issues, school rejected her admission. Since then, she goes to Anganwadi only. Attendance at the school is irregular, and reason for the irregularity is due to frequent health issues. There is poor peer group adjustment. Play history. Rather than playing, she usually observes other while playing. She prefers to play alone. There is no knowledge of games governed by rules. Her behavior while playing in a group situation is poor. And in leisure time, usually she watches television, usually Tarak Mehta, and uses phone, and in which she used to watch YouTube's comedy video, poem, and cartoon videos. Physical examination, height is 123 centimeter, weight 32 kg, shape of head is normal, face is normal, build, posture, skin, nutrition, hair and nail normal, no any physical deformity. Mental status examination, general appearance and behavior, 10-year-old female child looking appropriate to age, well-built, well-nourished, wearing appropriate clothes, entered into history-taking room with normal gait and posture, sat on the stool, but she would get up from her place repeatedly in between interviews. When I was having a conversation with her mother, she kept interrupting in between. Rapport was established with difficulty. Patient was partially cooperative, eye-to-eye contact initiated but not maintained. Psychomotor activity above average. Speech only speaks 1 or 2 words. Mood euthymic, affect appropriate to mood. Thought and perception, no abnormality elicited. Attention and concentration impaired. Abstract thinking impaired. Memory, immediate and remote memory impaired, while recent memory was intact. Judgment, personal, social, and test judgment was impaired. Intelligence. She didn't know the answer to general question like name of cities, river, days of week, number of month. When I asked about question like how many legs a cow has, or sun rises in which direction, or how many wheels are there in a bicycle, she replied one to all the questions. She was not able to do even simple calculation. She could identify the objects like watch, phone, and pen, but did not know its function. She could point out her body parts. She could not draw any shape, only scribbles. She did not know how to read clock, not able to identify color. When I asked her to pick the paper up from the ground with her right hand, hold it twice and give it back with her left hand, she did not understand the command. Adaptive functions, conceptual skill. She is unable to read, she is unable to write, but she can scribble. She can count 1 to 10 in English. She cannot prepare her bag, school bag. If she is allowed to do her homework alone, she keeps sharpening her pencil or she keeps rubbing on the paper with eraser and even tearing the paper. Social skills. She disrespects her elders when she is angry. She does not understand that she should not interfere while two elders are talking. In social situation, when she gets angry, she sometimes undresses herself and sometimes she comes out of bathroom without wearing clothes. When guests arrive at home, she usually greets them normally. Practical skills. She cannot bath alone properly. She cannot be trusted to cross the road alone as she doesn't comprehend the risk involved while crossing the road. She cannot differentiate between various currency notes and coins. She is unaware of her home address. She can start TV but cannot operate remote exactly. If a stranger comes when she is alone in the room, she understands that she should call her mother. From above history, the clinical impression is intellectual disability, moderate with behavioral disturbances.
Thank you, Dr. Himadri. I invite the experts for their comments.
Thank you, Dr. Himadri. This is your ICD-10 diagnosis,
DSM-5.
DSM-5, okay. And you said that it is intellectual disability moderate with behavioral disturbances. Can you give an elaboration of the psychosocial aspects of the case also? In terms of, does she have any
Wait, maybe you
physical?
can stop the slide share. Yeah. Please go ahead. Yeah.
Are there any physical disabilities that she has?
No, ma'am. No any physical disability.
Okay. There was in the history you said mentioned something about loss of consciousness.
Yes. At
Yeah.
the age of 3 years, there was a history of fall down, and after that, she got unconscious for 4 to 5 minutes. And after that, the mother described that there was uprolling of eyeball, no any exact seizure episode, but there was a history of unresponsiveness for 4 to 5 minutes after history of fall down.
Okay. So there has not been any seizure history subsequent to that.
Not
She was on some
exactly.
medication. She was on some medication which was
During first
sedative.
episode of fall down, there was no any history of medication, but after that, there was history of vomiting continuously for 5 days. So the investigation was done, and there was high blood ammonia level, and then she was started on some medication.
Okay. Would you like to comment on what that could have been hypothetically?
It could be any metabolic disorder or any urea cycle dysfunction. The exact cause is not known, as I have not reviewed the documents. But according to mother reported that the doctor told her that the ammonia level was high.
Okay. Yeah.
Meenakshi, ma'am.
Yeah, so do the residents want any other clarification? Residents, you all can put on your camera. Do you all want any clarification from the history? Okay, and where do you figure the your presenting problem was behavioral problems, right?
Yes.
That was the only complaint that they presented with.
Yes.
So where do you figure that in the diagnosis? They'll come to you for the management of behavioral problems, right?
Yeah.
I think she's already said that intellectual disability is severe with behavioral problems,
did?
right? Yeah.
Yes.
Okay. So the behavioral problems you have identified are the aggression and the
Yes.
irritability and the hitting, the presenting
Yes.
complaints that were there. Okay. In terms of assessments, you have given an overview of the history. What is it that you would want to do in this patient, in this case? How
Regarding
would
the
you
behavioral,
go? Yes, your diagnosis at present, as you said, DSM-5, ID, moderate with behavioral problems. So what is the assessment how would you go about assessing? You said
first, this is
history of seizures, you are not sure about that as
Yeah.
far as the past is concerned. With regards to, I think, the birth developmental history, you gave a whole history of delayed milestones, I think, especially speech more than motor, if I remember right, right? She's
So
still not
currently,
able.
no, ma'am. See, she can only speak one or two word sentences, not more than two, three words.
Yeah. Is there anything else that you would also consider? Is there a differential you would like to consider? There is a prominently, when you look at a differential aspect, motor versus speech, language delay, the language delay seems to be much more than the speech delay. Any other aspects of examination you could focus on?
Um,
How was the eye-to-eye contact?
the eye-to-eye contact was initiated but not maintained.
Okay. Anything else? Were there any repetitive behaviors?
No, ma'am. No any features of autism. Because her mother reported that the patient usually does not interact with the strangers, but at home or in a family member with the family member, the interaction, the eye-to-eye contact was usually normal. Which I noticed during interview, the behavior of the child with the mother and with other family members was normal. No any repetitive restrictive behavior in the
What
history.
would you understand by normal? This is an ID child with behavioral issues. Why would you say it is normal? What are the parameters you would take as normal?
Uh, how a child should behave with the mother or other family members.
Yes, so then that's what I'm saying. What is the normative behavior against which you made an assessment of this child behaving normally? Was it any particular any incident happened that you felt that her reaction was appropriate?
No, ma'am. During history, no any particular incidents.
No, because you said that she was behaving normally with her mother and the other relatives who had come with her, the caregivers who had come with her. So what was the normal behavior?
She was not interacting with me. No, she was not maintaining eye-to-eye contact, or she would not give answer the question I asked her. But when mother told her to do something, she was doing. She was maintaining eye-to-eye contact with the mother also, and she was also
Okay.
obeying the commands given by the mother.
Okay. What were the commands that the mother gave?
Like I asked her to draw, and patient was not following that. But when mother asked to draw something or to write something, she did that. But she was not
So,
able to write, but only scribble.
yeah. So then even drawing, you said she was just scribbling. She was not
Yes.
really making any sort
No.
of pictures,
No any
right?
shape or no letter.
Yeah.
So you gave a
Okay.
list of things that the child could do and could not do, but could you kind of group them into different aspects of clinically testing intelligence? When we test intelligence clinically, what are the different subheads that we test it in?
Like vocabulary.
Okay,
Mhm.
what else? Because
In a clinical,
you said
when you
15.
were to see this child, what are the clinical parameters you would take? Not about, testing as an IQ or DQ or whatever, but a clinical assessment for you.
Uh,
What are the
Conceptual
parameters you
skills,
would take
social,
into consideration?
Go ahead.
conceptual skills, social skills, practical skills, all are the adaptive functions.
Okay, adaptive functions is one. What else?
Before that, what would you, because you presented it first, in
Intelligence.
terms of the physical and the language, the motor and the language development milestone?
Yes. Yes.
And
Okay,
in
so that is one.
intelligence, what are the subheads?
Like learning or reasoning, abstract
No,
thinking.
you said vocabulary. Abstract thinking is another. Then what else?
Reasoning,
Asked her to
judgment,
follow a command, right?
yes, comprehension.
Judgment is not a part of intelligence testing. Although you need intelligence to have good judgment, but there are subheads when you clinically test intelligence. You said she could not fold a paper, pick a paper with right hand, fold it twice and return it with the left hand. What are you checking when you ask a
Comprehension.
child to do comprehension? So if she could not do those 3 steps, could you, like you already knew the child had probably ID, right?
Yes.
So how would you start? Would you straight away tell the child, pick up the paper with your right hand, fold it twice, give it back to me with your left hand? Would you do that or would you do it in a different way?
I first explained her, then I did the same thing.
Okay. But you know, comprehension of complex instructions. Before that you can check comprehension of simple
Simple
verbal
task.
commands, isn't it? How would you do that?
To show her right hand or
Yes.
show her left
Could
leg.
you do that? Because these are graded tasks, isn't it?
Yes.
You cannot have the same instruction for all patients. You have to start from the lower scale if you know there is ID. If she's able to do that, then you go to a higher grade, isn't it? So
Yes.
comprehension is one, vocabulary you said, abstract thinking or similarities is another one. What else do you check in intelligence?
General fund of knowledge.
Yes. What else? Is memory a part of intelligence?
Yes. Memory.
Isn't it? So, supposing now this is a child, you have reached the conclusion that she has moderate ID, but how much memory would you expect, say, for a 9-year-old, for a 12-year-old, for a 15-year-old? What would be the expected average finding?
Mhm.
Okay, now how will you manage this child?
First, I would like to confirm the diagnosis by doing applying the intelligence test. This is only the clinically the impression is that intellectual disability. But to confirm the diagnosis, I would apply intelligence test. Then, as there is a
Which
mainly the
one?
behavioral Bine
Which
Kamath
one would
test
you apply? Okay.
or
She's
Weierstrass test.
Binekamath is what kind of test? Is it a verbal IQ test or performance IQ test, or is it a mixed one?
Performance test.
Is it?
In this child, which would be much better preferred? She has delayed physical milestones, but her language milestones are much more delayed, no?
Yeah.
Anyway, if you were to formulate, give a diagnostic formulation in the sense highlighting the birth and developmental, the clinical symptomatology that she presented, your diagnosis we know. What would be your loose formulation? What are the areas? Because they have come to you for management. They also know that she's not a child who could be like any other 10-year-old studying in a regular school. So they know the problem with regards to her academics or her intellectual abilities. The problem behaviors are something they need you to handle. So what is your formulation in terms of her developmental, in terms of her development so far and the behavioral problems that she has presented with? Because the assessment would involve not only the IQ part of it, it would involve even that.
maybe the patient presented with a behavioral complaint. In the past history, there was a query seizure episode, and the one positive finding is the raised ammonia level, which was uh, occurred mostly 2 times in the past. In the family history, no any positive finding. In
Okay,
personal
just
history,
wait here. Just wait here. Why is it significant as far as increased ammonia levels? As you said, it was mentioned by the parent. A
yes.
parent is not really familiar with, lab findings and all.
Mm,
But this is something that they told you.
yes. Because
So
it,
what is
it
it?
occurred twice. So the mother also remembered that every time when there was a complaint of vomiting and the investigation was done, there was a high
What is
ammonia level.
what is the association with high ammonia and intelligence and developmental issues?
There can be any metabolic inborn error of metabolism.
Okay. So what are you going to be looking at? What does it indicate? Increased ammonia. At
Any urea cycle disorder.
which organ is affected? What is happening to the brain? Okay, anyway, so why I'm asking you is because you would have to also see what investigations to be done, no? If at all. I mean, for example, if they were planning any other child and they, came to you for any sort of assessment and counseling for that, it is also important for you to look into those parameters, right?
Yes,
What is it? This was a non-consanguineous marriage, you said.
yes,
It was just that it was an unwanted child.
yes.
So
It was unplanned pregnancy, and the
it was an
mother
unplanned,
did not want
did not
continue
want.
it.
She didn't want to continue. And here again, it was something that I missed asking you. When she didn't want to continue, what did she do? Did she go and use something, take something, went for a, medical termination, or she
Mother went
just,
for at the 3.5 month, 2.5 month. Mother came to know about pregnancy, and then she went to a gynecologist for termination of pregnancy. But eventually, after consulting other gynecologists and reviewing after family members' consent, she decided to continue pregnancy.
so she had not taken any medication at that
No,
point in time.
no.
Right. Is it
So
important?
if I may ask
Yeah.
the experts as to what actually should we keep in mind at this point? Let's say as a student, I am not aware of the answers, but I
Mm.
should be. So
Yes.
what
So
what
why,
would
yeah. So, I mean, if I have to ask or even inquire into this history, one is, as you said, about the consanguinity. Second is when you said that it was an unwanted pregnancy and it was an unplanned pregnancy, for example, and she went for some sort of termination, but she got counseled against it. That's what I understood. But sometimes what happens is they may go and take some medications where the abortion doesn't, I mean, the MTP doesn't happen, but the fetus has been exposed to something that would be potentially harmful. One. Secondly, what we have to remember is that when we are talking about a developmental, trajectory that you mentioned, that in her early development, she had high ammonia. Whatever it was, she may have had a seizure, she may have had a encephalopathy, a metabolic, disorder at that point in time. How did it impact? We would have to sit and track whether there has been a delay subsequently to that, which was much more than what it was her earlier development. Okay, in terms of a stepwise deterioration, that is something we need to see whether there has been something stepwise which has contributed progressively to more intellectual disability and more of the behavioral issues, right? And second part is that even at a psychological level, if you're saying that she was a lady who was probably not wanting this pregnancy, it is important to also go into how the mother through the pregnancy was actually in terms of her psychiatric status. That is also, it may not be relevant in terms of now we know this child is ID, but otherwise also we know when a mother who's psychiatrically unwell, whether depressed, it has an impact on the growing, developing fetus also. So that is a history that we would have to also take as far as the perinatal period is concerned. Okay. not only as in events, but as far as the perinatal psychiatric period for the mother's assessment. That is also something that we would, I think it is required that we need to make that assessment. Barring the fact that post delivery, how was the bonding? How was the interaction with the child that she had? Because that is another impact that she would have. Not only that the child is developing in the way she was, but what about the interaction that the mother had with the child, who she didn't want in the first place, and who then has significant issues with regards to physical and intellectual development. Okay. Yeah, ma'am, if you want to.
Meenakshi,
And another thought that crosses my mind is that probably the child had query seizures, was put on valproate. And a
Yes,
very
ma'am.
common side effect of valproate is hyperammonemia, isn't it? So you've not been able to see the documents, but that is again a connection that can be checked. So Binetamak is not a performance test. Okay. It's a verbal IQ test. What are the performance tests, or which is the one that you use commonly in your department? The psychologist might be using the performance test.
Wechsler's test, not pure performance
Wechsler's is
test.
a mixed one.
Mixed.
So which is the pure performance one? In Gujarat, we commonly use Bhatia Battery test, isn't it? Or progressive matrices, isn't it? Or sanguine form board, depending upon the level of the child. So those are the performance IQ tests that can be given, right? So what is fluid intelligence and what is crystallized intelligence?
Fluid intelligence is
Now we are going, okay, we can come back to the management also, but then this is a theoretical question.
fluid intelligence is what we learn from the experience, and crystalline intelligence is what we apply in a practical aspect from what we have learned.
So we have this saying in Gujarati, bhanaya pan ganaya nahi, right? So bhanaya, what we acquire by learning, by education, by memorizing from books, that is crystallized intelligence. Whereas the ganaya aspect, which is whether irrespective of education, your ability to adapt to change, that is fluid intelligence, and it is innate, it is biological, it is genetic, right? Okay, so coming back to your case, there are many things which suggest that this probably is a case of secondary ID. So you could go into the detailed inquiry of the milestones in the first 3 years, because at 3 years of age, the child had a history of some kind of brain injury. So before 3 years, if it was completely normal, then there are more chances that it is a structural kind of damage that has occurred to the brain. So now, anyways, they are quite settled into accepting that this is ID. How are you going to manage first the immediate problem, and then in the long term, how can you help the child and the parents?
As there are behavioral complaints, the aggression and anger outbursts. So, and also there is a history of high ammonia level. So we can start a low dose antipsychotic for the behavioral aspect.
Okay. What if I say that those with ID, they are more prone to side effects of antipsychotic medications? Do you have any other option? In your experience, are they more prone to the side
Yes.
effects of antipsychotic medications? They are?
Yes.
Then what would you like to start?
Valproate.
As valproate, we already have history of hyperammonemia, which is a known side effect of valproate. But you're in the right direction when you say we can start one of the anti-epileptic medications. So if not valproate, then carbamazepine or oxcarbamazepine, if titrated to an optimum dose, can help the behavioral problems, and they're also more likely to kind of, manage the brain trauma, or if there's a possible history of seizures, and you need to coordinate that with the neurophysician who is also treating, isn't it?
Any investigations you would not you would do, because this is a case of ID. You're doing the intellectual assessment, of course. Any other lab investigations you would want to do? Even otherwise, primarily because you will be starting on, you want to start on the child on medication, right? Are there any particular, anything that you would look at, considering there has been history of hypoammonia twice, basic investigation that you would require to do? As Madam said, of course, if you are, with regards to valproate, why you would avoid it is because of that history, but otherwise. Anyway,
Ma'am, if I may ask, role of liver function test in
Yes.
this case.
yes. It would be advisable to get a basic investigation profile to see where we stand, even if when we are addressing the child with medication, right? So it would be good to, even if we don't know, even if otherwise we do a basic hemogram, CBC count anyway. A liver function, because there's a history of hypoammonia, barring that, if you're planning to start an anticonvulsant anyway, it's always advisable. Anything else?
So what next?
Even otherwise, what are the parameters that you would think? One is the intellectual disability. Is there anything else you would want to do for the child in terms of probably the disability
Management.
that is there?
Speech
The
problem.
child is
the
going to an
speech-
Anganwadi, na?
Yes, ma'am.
So if you're looking at it from a psychosocial aspect, for example, if the child's parents are from a poor family, is there something that we could do for the kid? Something that will help them?
Basically, go ahead with the management. You said you'll manage the presenting problem. That's the behavioral problem. What else will you do in managing this child and parents?
Behavioral therapy to manage the anger and aggression. Then family counseling,
That-
family.
Okay. Family would probably be much more interested in something else more concrete that you could do for them, that Madam was hinting at. When you get the psychological test done, or formal IQ test done, you'll get a score, right? What can you do for the child and the parents?
How can we help them? What about the disability? How would you assess?
By doing IQ test, according to the IQ, mild, moderate, or severe, we can issue the disability certificate to the patient. And
Okay.
in moderate, if it would come moderate intellectual disability, there would be 75% of disability certificate we can issue. So the patient can have benefits in public transportation, and every month they are provided some money. Mostly it is 1,000 rupees per month. So that benefit can be given to the child.
So what is
So
the
if
act
you-
that covers all this? Just think. Do you know the
please go
act?
ahead.
A person with a disability Act, PWD Act.
Okay. Yes, ma'am. Please continue.
So if you give the IQ of 69 to a patient or 71, does it make any difference?
Yes, ma'am. Below 70, it would be mild ID, and more than equal to 70, it would be borderline ID.
So would there be any difference in the terms of benefits that they
Yes,
could
ma'am.
get?
Yes, ma'am.
Mhm.
For borderline ID, there will be only 25% of disability, And according to this Person with Disability Act, the minimum percentage of disability is 40%. If there is more than 40% disability, then only they can provide benefit. So in borderline ID patients, patient will not get any benefits. It should be at least mild intellectual disability to get any benefit.
Right. It's a kind of a loophole in our system that those patients with borderline ID who would benefit most with the benefits that the government gives and kind of become self-reliant, they are the one who are left out of any kinds of disability benefits. Right. So what else? How will you counsel the patients, the parents? What kind of tips would you give them? You said behavior therapy, but can you tell me a few tips that would be very useful to them? Some do's and don'ts, something like that. Behavior therapy is a broad title.
We can ask parents that the what incidents or what things that from which the child gets irritable. They can get those things from her environment.
They can get?
They can remove or they can avoid such stimulus in a child's environment.
So you did mention that when the child wanted something and did not get it,
Yes.
the child became very irritable and aggressive, right? So can you, the parents would ask you, what should we do when a child asks for something? The child will always want something or the other. So parents will ask you that how should we respond to the child's demands? What behavior therapy tips would you give regarding this specific issue? No?
Ma'am,
May
any
I,
role of
may I
ABA?
just make a suggestion, please?
Yes,
With your
please.
permission, ma'am. Can other residents also answer in the chat box so that they are just listening passively and only Himadri is in the hot seat. So I think they can also use their maybe
Yeah,
try
that's a
answering them.
very
There is
good
one
suggestion.
answer. Two. There are answers in chat box. Dr. Bansi Patel suggests token economy. Dr. Aparna suggests reinforcement techniques. Dr. Jinal Patel has also suggested the same.
Yeah, so these are all very good short notes to write on. But when the parents say कि हमारा बच्चा इस टॉय की जिद करता है, so how should we respond? So we don't say this, right? Positive and negative reinforcement or whatever. What would you tell them? So I'm sure whoever has written in the chat knows what to say. So please unmute yourself and speak away. Bansi, Jinal, and whoever else wants to pitch in.
It will be good a learning experience for everybody, including myself.
Nachiketa,
If we
don't
can
be so
discuss.
humble.
May I
Yes,
speak, ma'am?
please. Yes,
Parents.
please.
Yes, please.
Yes. Uh, we can explain parents that if child behaves properly and listen to them and obeys their commands for few days, and they can make give the child the thing which he or she likes, make a dish of his wish or something like that. And if child does not follow the commands or disobeys them and behaves improperly, then remove any uh, favorite thing of the child from the environment. Reduce screen time, does not give him or her phone for the free time, like
Yes,
that.
so you have given the very basic concept of giving something that the child likes or removing something that the child likes to make your therapy even more effective. What needs to be done depending upon the level of the child's IQ? Does this need to be set beforehand, or the parent observes and whenever the parent feels like gives something as a reward? What would be more effective?
I think beforehand would
Yes,
be better.
depending upon the level of the child's IQ, but if
Hmm.
at all the child is able to understand, you have to say that if this is done, you get this. If this is not done, you do not get this. So pre-deciding makes the behavior therapy more effective. What else?
This is all.
So
If I may,
the
Uniform,
yes,
yes, sir.
uniformity between both parents regarding demands
Yes.
that's a very
to
Yes, sir.
important
fulfill or to
practical
not
part.
fulfill.
Yes.
Yes, not just parents, but also grandparents, because they are the
Yes,
most indulgent.
relatives in care.
True.
Grandparents. And the child, however low the child's IQ is, he or she always knows whom to approach for what. So, Dada
Yes.
pasiti mani jase. So, yes, uniformity, that's another rule. What else? Bansi, you've unmuted yourself. Go ahead.
Yes, ma'am. We can say that we can reinforce the positive behavior by saying that if you do this for twice, thrice, or 10 times, we will give you the coin or like points for that, and after that we will give you some reward. So the child will do good things for more number of times, and he will also know the importance of the same.
Okay, that's also a good idea.
Sansi.
What else? Anyone else?
Oh, ma'am, a question from my
Um,
side. What about deals? Some children enter into deals that give me this, then only I'll do this.
So that I feel, and everyone can pitch in, but one thing is never promise anything that you do not intend to keep. For a child, that is the worst role modeling, I feel. Secondly, if the child's demand is justified, like if once in a while, once in a month or so, if the child is asking for a pizza or something, and you feel it is justified and feasible, then do not make the child beg for it or throw tantrums for it. If the demand is justified, then you should give it before the child asks for it or as soon as the child. You should say yes as soon as the child says that asks for something. If you have to, so these are the boundaries that need to be drawn. That if you know that the child is asking for, say, PlayStation, whatever the latest edition is, and you know that I can't afford it or I do not want to do it, then you do not indulge in no matter how much good behavior we will think about it or something. Parents, as parents, we are prone to give the easy answers. Pachi જોઈ લઈશું અથવા તું પહેલા આ કરી લે, પછી we will consider it or we will give it. But no, if you think that that is not feasible, don't entertain it at all. Our remaining extremely consistent is most important. And no, we cannot allow the child making deals because that is not a part of behavior therapy. There, the tables have been turned. In behavior therapy, the parent has to be in command. In disciplining the child must know who is the boss. When it is, we are now talking about disciplining before the child has reached the age where he or she is able to decide what is right and wrong on his own. After that, the child is the boss. I mean, because he no longer is the child. He's become more or less an adult or approaching adulthood. Then the tables can be turned and in fact needs to be turned. But before then, when we are behaviorally modifying the child,
modified.
then the parent has to be the boss. The deals don't work. And here I feel that when the parent expects to be obeyed, that is when the child obeys the parent. This is a very subtle thing in the mindset of the parent. But if the parents think that the बच्चा तो हमारा मानता ही नहीं है और कितना भी कर ले, मैंने ट्राई किया, इन्होंने ट्राई किया, आप कर लो ट्राई, बच्चा तो मानता ही नहीं, बच्चा नहीं मानेगा. So no matter, I mean, here I think these are innate behavior responses, and no matter what the IQ is, but if the parent expects to be obeyed, then the chances of the parent being obeyed are quite better than when the parent doesn't expect to be obeyed. So these are some of the tips. And of course, behavior modifications, the rewards that you give should be not unhealthy, and better if supposing I'll give you a nice book to color, or I'll give you a nice storybook to read, something that enhances the education of the child, then those are better forms of rewards. Yeah.
And the reward should be with and it should be, sort of attached to the behavior that you want to actually address. So the reward has to be contiguous with the behavior that you want to address, whether it is, the aggression or the anger whenever the child doesn't get something, or just having a temper tantrum when his demand is not met, for example. So that is important because, just giving a delayed reward, and especially in a patient like this, who is basically moderate ID, the scope for learning will be much less in terms of, so it has to be contiguous, it has to be repetitive. So it can be a little painful to keep repeating this, and it has to be consistent across all the caregivers who have to do the same things at the same time for the same behavior, so that the child knows that this is not to be done. That is because it gets reinforced with multiple caregivers doing the same thing also, especially in a child who is also behaviorally disturbed to this extent. I just had a question about, the scope of speech therapy. I think Himadri had said, in fact, it's open to the other PGs who are there. Is it possible that there would be any scope for speech therapy in a 10-year-old who has barely any expressive language? Anyone, it could be just, a commonsensical response. I'm not asking you all to sit and give me what a speech therapist would say, but then, because even when we are advising what should be done in terms of, assessments and what interventions can be done, because it is something that probably the parents will ask us, how much of speech therapy, because it's expensive. It may not be available to everyone anyway. So when we are referring, is it something that we will expect some sort of change? Then only we would sit and refer for that sort of change, right? It's an expensive intervention to have. It's something that may not be feasible in your city or town or in tier 3 cities. So we need to be knowing whether it is something that may bring about any sort of change, then only refer. So in a child like this, whether there is scope for change, advising speech therapy is another aspect that we have to consider. And how much? Because a child seems to communicate non-verbally anyway for the demands, probably with aggression. Here, probably behavior modification will help much more in terms of communicating and getting desired behaviors. I don't know whether so much of speech therapy may really help in a 10-year-old who has shown a deterioration over the past several years. I think it's open for other faculty to comment here.
Lakrawala sir wanted to say something.
Yeah.
I want to say that first of all, we should also ask the parents not to go for the doctor shopping, because parents with such child, they approach many doctors. They feel that some doctor will do some magic and my child will be quite okay. But we should explain the parents that this is the ID child, is a moderate IQ, and he or she cannot develop more IQ. Yes, we can behaviorally or the behavior intervention can we do, but for the increasing IQ, we cannot do anything because many parents come with such expectation.
Meenakshi ma'am.
That's also true. Yeah, so Nachiketa, what is the timeline? How long is this program?
So, ma'am, we can move toward concluding remarks, few points or take-home messages, and then there will be a short quiz session.
All right.
Official time is till 9 p.m. But it
Okay.
can be extended few minutes.
Okay, thank you. All right, so maybe we can take a couple of theory questions like what is Flynn effect? Anyone
Any
can
residents
answer.
can answer.
Flynn effect, Flynn.
If I can, ma'am.
Yeah,
Of
sure.
course.
So,
But you need to
this,
show us your handsome face.
uh,
Go
Yes,
ahead.
hello, ma'am.
better.
So Flynn effect is basically in which with subsequent generations, the intelligence increases with each passing generation. So if you compare the intelligence levels of, let's say, a few generations before, the current generation might be more on the same criteria or with the same set of tests, the current generation might be more intelligent. So our intelligent test should also evolve as the years pass by, as the generations pass.
Correct. So do you think the intelligence actually increases? And do you think there's some kind of ratio given for so many years? This is the increase in the IQ score?
Ma'am, there is a ratio given, ma'am, but I cannot exactly recollect it.
Okay. 3 points for every 10 years. That's
Oh,
what has
yes,
been
yes.
given somewhere. And do you think it actually increases, or what are the possible reasons for this?
Ma'am, the possible reasons may be that the adaptive intelligence increases with each passing generation. That's
All right.
possibly the only explanation that I can think of.
All right. Or maybe the brain is developing more, or maybe better nutrition is helping the brain evolve
Right.
more. Maybe
Overall,
because
Possibly.
there's
even the
better
milestones,
education
education, and even the
also.
milestones. Initially, eye-to-eye contact in a newborn used to take a few weeks, and now it takes 1 or 2 days. So
Yes.
maybe the brain is actually evolving.
Yes.
All right. Are there something like group IQ tests? Himadri, you can always answer, but everyone else can.
Dr. Prerna has
एक एक
mentioned.
इंसान को IQ टेस्ट देना. Yes, Nachiketa?
No, ma'am. Dr. Prerna mentioned with regards to the explanation for Flynn effect that it may be related to more exposure to things with each passing generations.
That's true.
Yes.
So, remember asking
Is there
about
any
group
concept of
intelligence.
group IQ? Yes,
Yes,
IQ test. Anyone?
Any competitive exams coming to mind?
होता है कि नहीं होता है? Well, there are group IQ tests, and usually they are used in army, and they are available in the form of performance tests as well as verbal intelligence tests. Yeah, the army IQ tests, and there's some other name also. The name is slipping by. But
Ma'am,
maybe
if I
someone
may
else
ask in continuation to this, what about SAT scores that we see keep getting mentioned in American context particularly?
So maybe it's not pure IQ, general IQ test, but it's a very specific kind of professional intelligence that is being tested. In that way, maybe we can extend the concept to all the professional entrance exams.
But I think most of these group
Jyotima?
tests that are there are basically, it's based on the group performance. So it's on the percentiles, not on the percentages that individuals get. So it depends
Yeah.
on how the whole group performs, which actually
Right.
dictates the base. So
Yeah.
the percentile
And when
system.
you talk about the percentile, anybody knows what is Mensa? 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 Nachiketa, you also can answer. Go ahead.
Yeah, it's basically a form of a club. Let's say we talk about 1%ers and 2%ers. So there is a certain level of cutoff, and if you are able to pass that threshold, then you are included in that special club of intelligent people.
So yes, it is an international forum which accepts as members only people above 98 percentile. And so the IQ comes to around 138 on a standardized IQ test. And if you get that, then you get an entry into that club. And apart from, very high to high interactions, it also promotes the research on intelligence. So with those few theory questions, maybe anyone else wants to, Shilpaji, you haven't asked anything, so please go ahead.
Shilpa?
No, I think most of the things were covered and the history was also pretty detailed. And both of you have covered most of the questions. I just
Any
think I also,
temperamental findings?
sorry?
Any temperamental issues in the child which can be assessed? It is also important. The temperament of the child.
Yes.
And who has given these concepts? There are different types of temperaments.
So who has given the concept of temperament?
Himadri?
Himadri?
Any of the residents, if they can answer.
I think Himadri has had quite a lot of answering of the questions being on the hot seat. I would like to compliment her on a very confident and well presented case. It was extremely interesting and it was very nicely detailed. In fact, I think, corroborating the expected developmental milestones with what was actually happening side by side was an excellent way to present. It gave a overall pictures, what was expected and what didn't happen in this particular child. And thank you, Himadri, for doing a very nice detailed workup. It's a very good case of ID. I would suggest, because they are postgraduates and you have to pass exams, probably going back to the IPS CPT guidelines is something that you all can all refer to also. It gives a very comprehensive outline of all the assessments that are required to be done. What are the investigations that need to be required, all the scales, the tests that can be done at different ages, and the interventions whenever required. Barring that, I would also add that when we go into a child's history, we have to also go into the mother's perinatal history and also about the generations before that, so you at least go back to a couple of generations to see. You have given that history of family history, but I think it is important to go into how the parents were and what is it that you talked about them, not the mother not wanting, but her perinatal history also is something that is important, and her, of course, interaction with the child in the early infancy. Barring that, when we are talking about interventions, multidisciplinary interventions especially, a lot of the multidisciplinary interventions, especially when you talk about speech, physiotherapy, for example, that works very well in early childhood. Very early interventions work very well. Probably in a child who has ID, who's older, some of the interventions may not work so well, whether it is speech or whatever. So it is, you have to also measure what is the intervention that work at which age, that is which would be much more effective. It is important because you need the parents to keep coming back and to be adherent for your treatment. So, just giving them a list of therapists that they need to meet may not really help. You would need to sit and identify what would help at that point in time and what are their concerns. Because in this child, I think it was the behavioral aggression which was becoming a problem. The child was just throwing things and being very, very aggressive and irritable with everyone. So that was the problem behavior that needs to be addressed, whether with medication, whether with behavioral intervention, or a combination of both. In this case, probably a combination of both. We would also like, I think beyond anticonvulsants, I would also probably say that, postgraduates need to also read about other treatments, other groups of medications which can be used for aggression, for irritability, and the underlying problems in a child who is compromised with regards to intelligence. I think that is something, MR basically, who has a lot of behavioral issues, how do we treat best without having a lot of adverse effects? And of course, all the other things with regards to disability assessment, the acts that are required, I think that is something that we need to round off in terms of, the questions that could be asked in such a case. Thank you.
And I think,
Yes,
sorry, a little bit about intelligence tests or assessments. Also, I think they need to know. Though we refer to a psychologist,
Yes.
that does not mean that we don't know about the tests.
Yes.
So, which tests are, even if they're not there in the institute, sometimes it's good to know because it could be asked if you're doing well in your case, and it could also be asked in your viva as well, table viva. So I think it's good to have a little bit know-how about intelligence tests that are done, because Meenakshi ma'am did ask about the tests, and I don't know how much, I don't remember Dr. Himadri answering, but I think it's a good idea to know about the test, especially if you have a child and ID moderate. Those questions are expected.
Yeah, definitely. And I think, which tests, whether they're verbal, non-verbal performance, and at what ages they need to be
Yes.
done. So, which is important because, whether it is below the age of 3 to 5, what is done, as, even developmental pediatricians are in the field in assessing these children. So, what are the tests done at that time, and what are the tests that we do, the children that we see later? Yeah.
So that is an expected question. If you have a 10-year-old and has a moderate ID, then you should know what tests that should be done and which, whether it's a combination or whether it's verbal or performance, that you need to know, I feel.
Yeah. I think
Yes, it
Nachikeeta has
was a
already put
good,
the article.
yeah.
yes, ma'am. 2019 CPG from IPS.
Yeah, you put the link. So it was a good presentation, Himadri, and you can all keep these suggestions in mind. And one more suggestion from my side is, if you get the time, then you should also prepare that diagnostic formulation, the 4P model. It will take into consideration all these histories of head injury or seizure and difficult pregnancy of the mother, and all those factors would be accounted in that 4P model. So that will be a very good touch to the history. Right.
Thank you so much, ma'am. Both Dr. Parikh and Dr. Jyoti Shetty. I think it was
Thank you
very
for giving me this opportunity.
It
Thank
was
you so
really
much.
wonderful. It was like an exam going on here, and there was some 50 when I saw last maximum number, 50 or 50 plus. So I hope all the PGs had that experience of having a child case during their exams, and what kind of question, I mean, how to present first of all, because Dr. Himadri did a very good job at it. And then what questions are asked and what the discussion goes on to in such a case. So I think it was a wonderful session and I hope they learned from this. Thank you, Dr. Parikh and Dr. Shetty.
Thank you so much for inviting.
One common question is asked that what is the verbal divided by performance IQ, or mental age upon chronological age. So what
Is
should
the
be the
formula of
chronological
IQ.
age? Yeah. What should be the maximum chronological age?
It is 16.
Why?
Because beyond 16 years, the IQ cannot increase. Up to 16 years, we can consider the chronological age.
So if the 50 years old person comes to you, then IQ becomes 0. Okay, so that's why it is kept at 16, not as per the real age of the person. Mental age is different. Thank you.
Important point, sir. And I will invite Shilpa ma'am to share a few words of gratitude for our speakers, experts, Meenakshi ma'am and Shetty ma'am, and yes, ma'am. But then the discussion continued. So,
So
we conclude maybe
thank
here
them.
and move on to quiz.
Yes, I thank them once
Yes,
again.
please.
I
Yes, ma'am.
also thank Dr. Nachiketa for moderating the session. And I thank all those present here who attended and participated also. So thank you, everyone. And we can move on to the quiz. And I also request all
Yes,
the
ma'am.
PGs to give the feedback. I think Dr. Nachiketa has already shared a link for feedback.
Yes, ma'am. I have shared the link in chat box. I can share it again also.
Okay.
So now we move on to the quiz section. Dr. Prerna Khar from quiz subcommittee would be taking over the session. Over to you, Dr. Prerna.
Thank you, Dr. Nachiketa. A very good evening to the respected chairpersons, Dr. Shilpa ma'am, Dr. Jyoti Shetty ma'am, Dr. Parikh ma'am, and Dr. Bhavesh Lakdawala sir. Just before we begin with the quiz, apart from the IPG, the IPS CPG guidelines on intellectual disability, there's also an ICAPAP textbook of child and adolescent psychiatry, which has a chapter on intellectual disability, which very lucidly summarizes, things from various textbooks. And it's a very simple, easy to understand chapter. It's freely available online. So you all can also download that chapter from the ICAPAP website and go through the same. I think today's discussion was very enriching and a very thorough discussion on the biopsychosocial model of intellectual disability. So just as a recap for all the participants, we'll take a short quiz of around 5 minutes with 10 MCQs. Can I request Mr. Yogendraji to please share the Zoom poll? Okay, so you'll have to answer all the questions. I'll start reading one by one. The first question is, which of these tests do not measure the intellectual quotient of an individual? Woodcock-Johnson test of achievement, Wechsler's intelligence scale for children, the Bene-Kamer test, the Mullen's intelligence scale for children. Please select the answers on your screen. Everyone will get a poll option. Moving on to the next question, which of the following physical attributes is not seen in Down syndrome? Simian crease, sandal gap, mongolite fissure, large forehead. The third question is, which of these subsets of Wechsler's intelligence scale for children measures the performance intelligence for a child? Information, object assembly, arithmetic, or vocabulary? So WISC measures performance intelligence as well. Which of these subsets gives you performance intelligence?
Remember, there is some issue with poll. Few people are not able to see it.
Doctor,
Yeah, the poll is not visible.
not visible. Yogendra ji, can you check that?
Can I relaunch it?
Yes, please relaunch it.
So meanwhile, the poll relaunches. I would request Dr. Prerna ma'am to share that ISEAP link, that chapter link, or at least the key phrase that we can search in Google.
Yes, I'll just share the link of the website.
Can I relaunch it?
Is everybody able to see the poll?
Yes.
Participants can reply in chat box whether they can see it or not. As for me, I'm not able to see.
No, it is so. No, it is available.
Okay, there are few
Some of the
participants who
members
can't
are
see
not
it,
seeing.
Yokendra ji. I think you may have to relaunch it.
Yeah, I have relaunched it.
Please do it again because some of them are still not able to see the poll. Is it available now on your screens?
Just a minute. Relaunch.
Can some participants respond if they can? See
Yes,
it?
it is seen now.
Okay. All right. So I'll quickly start with the first question. Which of these tests do not measure the IQ of an individual? The Woodcock-Johnson test of achievement, Wechsler's intelligence scale for children, the Benny-Kamer test, Mullen's intelligence scale for children. The next question is, which of the following physical attributes is not seen in a child with Down syndrome? Simian crease, sandal gap, mongoloid fissure, large forehead. The third question is, which of these subsets of Wechsler's intelligence scale for children measures the performance intelligence? Information, object assembly, arithmetic, vocabulary. The fourth question is, WAPIS is a measure of verbal IQ, performance IQ, global IQ, or full-scale IQ. The next question, which of these IQ tests can be administered in a group setting? Raven's progressive matrices, sanguine form board test, Benny-Kamer test, Wechsler's intelligence scale for children. The next question is, which of these tests has been approved under the Rights of Persons with Disability Act to assess the IQ for children for the purpose of disability certification? VSMS, SFP, RPR, or DQ? Question 7. A child having an IQ of 85 would be having borderline intellectual functioning, mild intellectual disability, dull normal intelligence, or average intelligence. Next question. A male child was brought to the OPD with academic difficulties, difficulty understanding age-appropriate instructions, few features of autism, macroorchidism, and a large prominent forehead. He is likely to have which of the following syndromes? Down syndrome, Prader-Willi syndrome, Fragile X syndrome, or Angelman syndrome? The next question, while calculating IQ using BKT, what is the basal age? Is it the age at which all items have failed? Is it the physical age of the child? The lowest age at which all items are passed, or the highest age at which all items are passed? And the last question, the ceiling age for BSMS is 10 years, 15 years, 16 years, or 12 years? I think everyone has finished the answers. We'll give you all a minute more to complete the quiz. And please end the poll once you have finished answering. So far, we have achieved only 15 responses for each question. I think there are probably 31 participants or around 25 if the chairperson and us are excluded. I think we can end the poll. Dr. Nachiketa?
Yes, ma'am. Yes, surely. Yes. We can end the poll and move on to declaring the previous results.
Yes. So before that, should we discuss the answers for today's quiz?
If the answers are already finalized and poll has ended, we can, I think, in brief.
Yeah.
Okay, so I think Yogesh, you can end the poll.
I read it the poll number.
Okay. So the IQ test which is not, or the test which does not measure the IQ of an individual, the first question, the answer is the Woodcock-Johnson test, because that measures it's a test of achievement which is used to assess learning disability of an individual. So a large forehead is not seen in Down syndrome. Among the subsets of WISC, it's object assembly, which gives you a measure of the performance intelligence. And WAPIS is a test of performance IQ. It's a modification of the base or the WISC. I think we discussed this question also when ma'am was having the discussion related to the case. So one of the tests which can be administered in a group setting is the Rabin's progressive matrices, which often gives you a percentile. And VSMS is the test which has been approved under the RBW Act to assess IQ for the purpose of disability certification. Moving on to the next question, a child having an IQ of 85 would be having dull normal intelligence. Now the case scenario which was presented, the child most likely is going to be having Fragile X syndrome. I think this was also discussed in during the case discussion. So while using IQ, calculating IQ using the BKT, the basal age is the lowest age at which all the items are passed. And the ceiling age for VSMS is 15 years. So I think that completes the quiz. And moving on to the winners of the previous quiz, which was part 2 of mental status examination. So there were 4 PGs who got a score of 8 out of 8. The first one is going by the login ID of Red Woman. If they are present here, they can just show themselves. We also have Shruti Tagre, Kaushik Bichwas, and Jeel Vasa. So they are the 4 winners of the previous quiz. Congratulations to you all. And I would like to end the quiz. Thank you for the opportunity.
Thank you, Prerna.
Thank you, Dr. Prerna. Yeah, ma'am, please go ahead.
No, I just did not thank her. So
Thank you, ma'am.
Yes, ma'am.
nice quiz. And as I said earlier, how psychological tests are equally important. So it just reiterates it, that those who answered would have realized it. And thanks once again.
Thank you.
Thank you to the quiz committee as well. Thank you.
Yes.
I think Dr.
Thank you
Ashish,
all.
I
It
saw
was a
over here.
great evening. Logging out.
Thank you. Good
Thank you.
night, everyone.
Thank you.
Good
Good